Hey guys, it's Kathleen, lecturing on mental illness in the primary care setting, diagnosis and management. Also going to give you a chapter of reading, chapter 18 in another textbook, which I'll scan and upload for you to read, which will follow along with the lecture and the case studies in class today. When we talk about primary care setting, this is probably one of the biggest challenges we'll have, and it's something, unfortunately, you're going to be dealing with quite a bit. I would like to put a little bit of plug in for you. You need to get really good at this. And that takes practice, that takes networking with psychiatrists and clin specs who can prescribe, as well as any NP that's a psych NP. And we have in a program here, and I'm not like marketing for UMass Dartmouth, but you should think about getting your psych NP because you'll be very marketable, and God knows what kind of business you'll be in, what kind of practice you'll have, and so forth. And if you don't feel like doing that, you just get trained on the job by someone that really understands, and I want to tell you, understands addiction. And it's part of the reason why you guys are going to the methadone, because a lot of this goes hand in hand with substance misuse. So depressive disorders, major depression, MDD, this is characterized by unipolar mood disorders, which are characterized by physical and psychological symptoms that cause significant distress and impairment and occur in the absence of elevated mood, mania or hypomania. So they don't have this. So some of the atypical features could be difficulty, unable to sleep, overeating, lethargy, and rejection sensitivity. You can have major depression with seasonal onset, and that's basically the dysfunction of circadian rhythms that occur more commonly in the winter months and believed to be due to decreased exposure to light. Common symptoms include carb craving, lethargy, hyperphagia, which is like this serious eating disorder defined as being extremely unsatisfied and driven to consume lots of food. Major depression with postpartum onset, again, any pregnant women or a woman that you're seeing after she had a baby is really at high risk. You need to screen, and this depression usually occurs between 2 weeks to 6 months after giving birth. Dysthymia is a chronic depressive disturbance. Patients are sad, there's loss of interest, withdrawal from activities over a period of 2 or more years. And this is a relatively persistent course is necessary for this diagnosis. Generally, with dysthymia, the symptoms are milder but longer lasting than major depressive disorder. You also have premenstrual dysphoric disorder, which is depressive symptoms during the late luteal phase, the last 2 weeks of the menstrual cycle. I also want to put a plug in here. Depression is a risk factor for high-risk behaviors and substance misuse. So depression is a risk factor for high-risk behaviors and substance misuse. So the etiology of depression, there may result in a multitude of factors. They can be biologic, which have to do with the neurotransmitters, structural changes, genetic predisposition, there's a family history, psychoanalytical etiology, mourning, negative thoughts, negative self-view, developmental factors, which could be childhood events, personality disturbances, and cognitive distortion. And then there's also the environmental factors that can lead to depression, and those are stressful life events. And stressful life events are someone that has just lost their job, is going through a divorce, or has a medical condition that's terminal. Most people with depression seek and receive treatment in the primary care setting. Okay, so that's why we have to get good at this. Lifetime prevalence of a major depressive disorder is 15% for adults between the age of 18 and 65. At any given time, 5.3 to 8.5% of the population meets diagnostic criteria. Women are twice as likely as men to experience major depressive disorder in their lifetime. Depression is most often diagnosed around the age of 30, and suicide is the third leading cause of death in Americans from the age of 15 to 24. If you have a patient that's diagnosed with depression at the age of 30, the symptoms often start 10 years earlier, and treatment is not sought until age 33. Depression is underdiagnosed and undertreated, yet it can be diagnosed in less than a few minutes and is very treatable. Some other stats is psychosocial and mental health problems constitute about 22% of primary care visits. So psychosocial and mental health problems comprise about 22% of primary care visits. In the last decade, there has been a substantial increase in the number of people living with serious mental illness and substance misuse disorders who receive care in primary care offices and ED departments. 15% of those diagnosed with major depressive disorder die of suicide. Only 50% with major depressive disorder receive treatment. Dysthymic disorder occurs up to 7 times more often in women than men. And 47% with a history of major depressive disorder also meet criteria for anxiety disorder. So you're dealing with two different things. 5 to 10% of those with depression also have coexisting thyroid disorder, so you have to rule out, is this a medical condition? And prevalence of depression does not differ among races. Two 2% of children get depressed, and 6 to 8% of teenagers, 1 of every 10 American high school students reported making a suicide attempt the year before. Teenage boys are more likely than girls to kill themselves. As a provider, you want to look for a change in behavior or performance in school. That's a red flag. Depression, there is an equal incidence between girls and boys before puberty. After puberty, girls 2 to 3 times more likely affected. Higher risk in children with apparent with major depression. So when you take that history, that's a risk factor. So really hone in on that. Make sure you give the adolescent a self-rating scale on their mood, and then a scale that you can ask them yourself. An episode prior to 10 years of age associated with recurrent patterns. In other words, before the age of 10, you're most likely to have recurrent patterns of depression. Routine screening for all adolescents between the ages of 12 and 18 years for major depression in primary care is required, and most offices have it embedded within the electronic medical record. If not, you do it. Differentiate between depression and dementia. This is an important stat. It's 20% of patients with Alzheimer's type dementia are thought to suffer from depression. Elderly are less likely to complain of depressed mood. They have more somatic complaints, and the suicide risk is 50% greater. An elderly person can say, I'm weak, I feel weak as a kitten. And, the hip, the back. A lot of those complaints that really, they look good, but they're complaining a lot. So you want to make sure you rule them out for depression as well. There are several hypotheses for the pathophysiology of depression. Biogenetic amine hypothesis. This occurs as a result of depletion of serotonin. There's also a theory on receptor supersensitivity hypothesis, and this results from supersensitive catecholamine receptors in response to decreased levels of catecholamine in the brain. Genetic predisposition plays a role. There's evidence that patients who respond to an antidepressant medication that has been, if they've been on an antidepressant medication, they're more likely to respond to a medication that maybe their mother was on and was successful at that. So you might want to ask, is your mother on this medication? How'd she do with it? She did well. You might want to stick with the same medication. And you want to take the history and document that for your reasoning as medical decision making as to why you came up with that medication. So clinical presentation, that's multiple symptoms. A major depressive disorder requires at least 5 symptoms to be present, and symptoms are present nearly every day during a 2-week period. Symptoms that are clearly due to a medical condition or mood incongruent, delusions or hallucinations should not be included. So delusions or hallucinations should not be included in the clinical presentation of depression. It's something else. So with the diagnostic criteria for a major depressive disorder, they must have either depressed mood or loss of interest or pleasure. Must have 4 other symptoms, and those could be significant weight loss, gain, decreased or increased appetite, insomnia or hypersomnia, psychomotor agitation or retardation, loss of energy or fatigue, feelings of worthlessness or excessive inappropriate guilt, diminished ability to think, concentrate, and very indecisive, recurrent thoughts of suicide or death, and symptoms cause the depression symptoms cause significant distress or impairment in functioning. And this significant impairment can include social, occupational, or other important areas of functioning in their life. So inability to experience pleasure from activities usually found enjoyable, for example, exercise, hobbies, music, sexual activities, or social interaction. Dysthymic disorder is depressed mood for most of the day, for more days than not, for at least 2 years. During periods of depressed mood, at least 2 of the following additional symptoms your patients will need to have: appetite disturbance, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. Diagnostic criteria of minor depression: presence of fewer than 5 symptoms. Duration of symptoms must include depressed mood, loss of interest or pleasure in most activities, and symptoms must persist for at least 2 weeks. So who are at risk for depression? Anyone with family history of depression, so anyone with a history of depression is at risk for developing depression again. Also, anyone whose family members, mom, dad, brother, sister, also has depression. E2H and substance misuse are a big risk factor. Psychosocial stressors, there are 3 categories. There are major discrete stressors, which include deaths, divorce, job loss. Chronic stressors are marital conflict, abuse, ongoing chronic illness in patient or family member, and minor daily stresses, demands at work or home that may be causing patient to feel overwhelmed. Female is also a risk factor. Age, postpartum period, also again a risk factor, and lack of social support. So diagnosing depression, you want to do clinical interviewing, a good medical review of systems. We want to make sure that we're not diagnosing depression and it's something medical. Evaluate risk behaviors, evaluate are they having impairment with their friends, or are they having trouble at work. Objective findings, you want to do complete physical, and self-report questionnaire, which I'm going to give you a whole page on many self-report questionnaires and other scales or questionnaires to use to actually screen your patients for depression. Make sure you do a neuro exam, a very thorough neuro exam. There's a good book if you're interested in misdiagnosis of diagnosing someone with depression or psychotic issues. And it was really a medical condition. The name of the book is Brain on Fire. I'm reading it right now. It's pretty good. And as a future NP, it's a good book to read when you have a spare moment. Essentials of diagnosis. Present in most depressions, and that is like the patients ruminate, constantly ruminate, which may become persistent, recurring, worrying, brooding over something. The patient's mood often varies from mild sadness to intense feelings of guilt, worthlessness, and hopelessness. They have trouble thinking, including concentrating, and they're not able to make decisions. They lose interest, and they also diminish involvement in work and recreation. Patients also complain of somatic complaints such as headache, excessive sleep, loss of energy, change in appetite, and decreased sexual drive. They're also very anxious. In this next slide, it talks about what some of the symptoms that occur in severe depression, and that's psychomotor retardation or agitation. Patients can they just complain about everything, or they feel persecuted. So I always think of like someone like when we talk about hypochondriacs, I always think of this, and you can tell me that I'm inappropriate, but it's someone that would complain of an ass ache. It's just, they just complain about everything. They're draining to be around. Withdrawal from activities in major depression. Physical symptoms of major severity are anorexia, insomnia, reduced sexual drive, weight loss, and various somatic complaints, and suicidal ideation. If someone's manic and they need to have these mood ranging from euphoria to irritability, they have sleep disruption, they're hyperactive, they have racing thoughts, they're very grandiose, and they can have variable psychotic symptoms as well. So what do you want to ask? You want to ask the patient when they present, when did this start? How long has it been going on? What are the descriptions of the symptoms that they're having? You can use a brief screening tool, and I'm going to give you, there's many of them. There's Hamilton screen, there's Zung screening tool, there's Beck Depression Index, and I'm going to give you a whole chapter. There's 2 pages on the type of screening tools you can use. You want to ask the patient, are these symptoms new? And if they are, have they ever occurred before? Does the patient have a past psychiatric history? Ask about the impact of the symptoms or their level of impairment. Does this patient have difficulty functioning? How are their interpersonal relationships affected by the patient's symptoms? You want to ask about presence of identifiable stresses, like the major ones, like loss of job, divorce, and so those, which I had on the previous slide, which are the major discrete stressors and the minor stressors and the chronic stressors. And then you want to ask, does the patient have difficulty functioning at home, school, work? So major discrete stressors, just to review, are death, divorce, job loss. Chronic stresses are marital conflict, abuse, ongoing chronic illness in patient or family member. And minor daily stresses, demands at work or home that may be causing your patient to feel overwhelmed. What you want to examine. Physical exams should be directed toward ruling on infectious, neoplastic, metabolic, or neurologic disorder. Complete exam. You don't want to diagnose someone with depression if they have a medical condition that you missed. So part of the mental status exam is completed during the health history, but you also want to take a look at the patient's general appearance and behavior. You want to observe inattention to personal appearance. Are they tearful, downcast? Are they able to give good eye contact or poor eye contact? Is their affect constricted or intense? Is their mood frustrated or sad? Is their speech mostly soft or low with little spontaneity? If inattention occurs, you should document during the exam by testing their ability to recall a series of random numbers. So I'm going to give you these numbers and I want you to recall them back to me. 15, 20, 1. Okay, 15, 20, and 1. And then go 10 more minutes later and then ask the same question again and see how their recall is. The task force suggests screening using one of the available screening tools. Those are all the ones. But we must rule out organic causes. And so there you want to rule out medical causes of depression. You want to look at CBC, iron, B12, folate, chemistry profile, thyroid. Make sure it's not the thyroid, the low thyroid that's causing them to be depressed. Syphilis screening and SED rate. An increased SED rate could be an autoimmune disorder that could be causing it, and it would depend on the patient's presentation. And again, we want to do self-report scales. These are common scales, and they actually ask very detailed questions about depression, and it is a tool to screen. You also want to look at the differential diagnosis of patients with depression. These are viral infection, hypothyroidism, hypoparathyroidism, hypoadrenal corticism, leukemia, lymphoma, cancer, cerebral vascular disease, MI, vitamin B12 deficiency, malnutrition, traumatic brain or spinal cord injury, or other psychiatric disorders. Some medications can cause depression, or cardiovascular drugs, anti-Parkinson's drugs, anti-anxiety, anti-inflammatories, anti-infectives, antibiotics, stimulants, hormones, and antihistamines. You must rule out a serious organic cause for depression first. The organic cause might be causing depression and anxiety symptoms. Other differentials for depression are bipolar depression, psychotic disorders, particularly schizophrenia, bereavement, substance abuse, dementia, anxiety disorder, and medical conditions. There are many people that suffer from mental health issues that are depressed but have other underlying issues. There is so much stigma against those suffering from mental illness. It's frightening. So as a provider, you want to make that connection because a lot of people with schizophrenia who are undiagnosed are ashamed and don't want to talk about it, and afraid what their family would think, what other people think. And you see a lot of schizophrenic and people who are mentally ill using lots of substances because they can't deal, and they don't have the services available, and they don't know who to turn to, because it's not like you can talk to someone in your family that you're hearing voices, or they seem more irritable. A lot of schizophrenics will smoke pot as well, just to quell the feelings in their life. Approximately 80% of people with depression improve with treatment. They get usually most likely full remission of symptoms. We want to restore, be able to have them go back to work, and be able to function within their relationships. We also want to reduce the likelihood of relapse and recurrence, and that depends on how we practice and how we follow them up and how we educate them. There are three types of treatment for depression. One is psychotherapy, medication, and ECT treatment. Psychotherapy, there are two classes primarily prescribed. Those are SSRIs and SNRIs. And SSRI stands for Selective Serotonin Reuptake Inhibitors, and SNRIs are Serotonin and Norepinephrine Reuptake Inhibitors, and also Tricyclic Antidepressants and MAOIs. So the selection guidelines, when you decide what type of medicine you're going to put the patient on, you want to look at the adverse effects profile of the medicine, the needs of the patient. You want to look at if the patient was depressed in the past and they did well on this medication, will that be the same medication you go to? You want to look at the cost, especially patients who pay out of pocket. There are non-pharmacological therapies that need to be blended in with pharmacotherapy. Meds are not the only thing. Patients have to be accountable and work towards the goal too. This may be a non-pharmacological therapy may be considered an alternative for patients who are reluctant to use pharmacotherapy. The role is to support and augment medications. Example include psychotherapy, counseling, exercise, behavior changes. When to refer to a specialist, very, 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 very important. Patients who admit to suicidal thinking have a realistic plan and have access to weapons. Women who are pregnant or plan to become pregnant. Patients with no evidence of social support. Patients who are disabled by their depression. Patients with comorbid conditions. Children and adolescents with depressive disorder. Patients who fail to respond to one or two adequate trials of antidepressants. Patients who are disabled by depression are unable to function at work, school, unable to take care of the day-to-day responsibilities. Comorbid conditions or co-occurring psychiatric conditions that oftentimes occur with depression are, again, ETOH, drug abuse, anxiety disorders, OCD, somatization disorders, sleeping disorders, personality disorders, grief and adjustment reactions. Co-occurring psychiatric conditions are a red flag, and again, the stigma. They don't have anyone to talk to or turn to, and they feel awful about themselves. Barriers to treatment. Inadequate assessment, misdiagnosis. There are comorbid conditions such as diabetes, stroke, cancer. Substance misuse. If they're using substances, they're most likely aren't going to be adherent to the medications they need to take. Lack of available resources should be upfront. Poor continuity of care. Inappropriate medication dosing and titrating. Lack of behavioral health treatment providers in rural areas. inappropriate medication dosing and titrating. That's the close follow-up we're going to talk about when you prescribe medications to people who are depressed. Assessing for suicide risk, always on these patients. Here's an example. Include very specific questions. It sounds as if you are having a really hard time. Do you ever think of hurting yourself or taking your own life? Those are questions that need to be asked. If their answer is yes, you want to follow up with, when you have such thoughts, are you able to put them out of your mind, or do you find yourself dwelling on them? Do you feel that you might act on these thoughts, or do you have a plan? So suicide risk factors are patients who feel hopeless, that are white, Caucasian, that are male gender, that are over the age of 65, that live alone, who have a personal or family history of suicide attempts, and also a personal and family history of alcohol and substance misuse. Any patients with suicidal thoughts must be referred for emergency psychiatric evaluation. 1 out of 7 patients with recurrent depressive illness commit suicide. And of those who do, 70% were seen by their PCP within 6 weeks before committing suicide, often for somatic complaints. So in other words, they're not coming out and telling you they're depressed. They're complaining about every other thing. Screen them for depression. Identify and treat co-occurring general medical disorders like stroke, dementia, diabetes, CAD, cancer, chronic fatigue syndrome, and fibromyalgia. Identify associated medications that can cause depression, and those are antihypertensive hormones, H2 receptor blockers, anticonvulsants, levodopa, antibiotics, and antiarrhythmics. You want to make the diagnosis, and you want to select and initiate treatment. You want to monitor acute treatment every week. Assess response at 6 weeks. Are they clearly better, somewhat better, or not better? And there's an algorithm I want you to refer to as well that is also in this handout for your depression. So if they're clearly better, you want to continue treatment for 6 weeks. Complete remissions, continue medication for another additional 4 to 9 months, and consider maintenance treatment. Somewhat better, continue treatment or adjust dose. Monitor every 1 to 2 weeks. Assess response at week 12. If no treatment, then refer to psychiatrist. Psychotherapy, that is used for less severe depression, can be used for not chronic, recurrent, and disabling. And no psychotic features. These patients need to be in-house. Prior response to therapy, what did they have the last time they were depressed? Did it work? Don't deviate from that if it worked in the past. Use the same medication. Medication contraindicated or patient preference. So patients on a medicine that's contraindicated, so you have to find a medication that doesn't interfere with the meds the patient's on, or the patient's preference. What would they want to be started on? When to add pharmacotherapy. More severe symptoms, chronicity, recurrent episodes, psychotic features, treatment, family history of depression. Do their family members have depression? And what were their history? Were they institutionalized, non-institutionalized? How are they doing now? If they've been treated for depression, you want to know what medications. Incomplete response to psychotherapy. They didn't stay. They didn't like therapists, or they did stay and they really got a lot out of it and they're continuing to go, but they feel not as good. They feel like there's a chemical imbalance. And then patient preference for their treatment choices. So etiology could be biologic, which again, there's a defect in the neurotransmitter. There could be structural changes or genetic predisposition. So dopamine, norepinephrine, and serotonin work together to determine the mood. So dopamine, norepinephrine, and serotonin work together to determine the mood. Any abnormality in any of those neurotransmitters, which is serotonin, norepinephrine, dopa, and gamma, which is GABA, G-A-B-A, any dysregulation of the serotonin, norepi in the brain are strongly associated with depression. Dysregulation of serotonin and norepinephrine in the spinal cord may explain an increased pain perception among depressed patients. Imbalances of serotonin and norepinephrine may explain the presence of both emotional and physical symptoms of depression. So structural changes in the brain influence emotions, like the prefrontal lobe and the hippocampus. The hippocampus is like this long, elongated ridge that extends over the floor of the descending horn of each lateral ventricle of the brain. And that consists of gray matter covered in the ventricular surface, while white matter is involved in forming, storing, and processing memory. Genetics, there is some evidence that medications that worked in a first-degree relative will be effective for a patient. Treatment choices, ECT. These are used for severe major psychotic depression not responding to combined treatment associated with neurovegetative symptoms, marked functional impairment, and we've tried other treatment and it's not responsive to other therapies. Light therapy, mild to moderate seasonal depressive episodes. The recommendation for light therapy must be with a full spectrum light. Works best if used in the morning, sit in front of the light in winter, used with people with seasonal affective disorder. And that's that full spectrum light is light that covers the electromagnetic spectrum from infrared to near ultraviolet. So pharmacotherapy, what are the major classes? These are selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, monoamine oxidase inhibitors, MAOs. All of these are equal in efficacy. They do have different side effects, toxicity, and ease of use. 65 to 75% response rate. All of these antidepressants, if they work on the different inhibitors or receptors, they boost the synaptic action of one or more of the dopamine, norepinephrine, or serotonin, those three. So all effective antidepressants boost the synaptic action of the dopamine, norepinephrine, and serotonin. And there's a 65 to 75% response rate. So SSRIs are the first line of treatment for depression due to the safety and efficacy of the drug. This drug is an enhancing neurotransmission, enhanced neurotransmission by inhibiting serotonin reuptake at the presynaptic terminal. This is well tolerated and considered safe in overdose. Abrupt discontinuation may cause discontinuation syndrome. It is really hard to kill yourself with SSRIs. Patients on SSRIs are more likely than patients on tricyclics to attempt suicide, especially true in the first few months of treatment. Necessary to monitor patients closely during this time period. Prozac is a potent inhibitor of cytochrome P450 enzyme and is associated with many more drug interactions than any other SSRI. So remember that Prozac is a potent inhibitor of P450 enzyme and is associated with many more drug interactions than other SSRIs. Discontinuation syndrome of SSRI causes ringing in the ears, vertigo, paresthesia, and anxiety. So initial dose for Prozac, Zoloft, Paxil, and Lexapro. Know that the target dose, we want to get to the target dose, but some people we might not be able to. So again, that's close follow-up within a week, see how they're doing, make sure they're not suicidal on these meds. And then you can go up to the step-up dose. I would not recommend step-up dose without consulting someone who's an expert in this field. Initial doses on these medications should be reduced in frail or elderly patients or anyone with hepatic or renal dysfunction. Target dose is likely to be effective for most patients. Step-up dose is a dose above which most patients would not derive any additional benefit. Selective serotonin reuptake inhibitors, adverse effects of GI distress, dry mouth, sexual dysfunction, retrograde ejaculation, loss of sexual drive, erectile dysfunction, CNS stimulation, nervousness, agitation, insomnia, ringing in the ears, and headache. Serotonin syndrome is life-threatening. Caused by co-administration of any drug that increases serotonin. And those are hypertension, tachycardia, hyperthermia, flushing, sweating, diarrhea, and mental status changes. Drugs that increase serotonin include MAOI, lithium, dopamine, agonist, tryptophan, and amphetamines. So how to choose? How do we choose? Fluoxetine has a long half-life, activating very good for people who can't sleep, who have a lot of apathy and fatigue. Not so good with agitation, insomnia, and anxiety. Very helpful. Sertraline is very helpful for those with low energy, unable to sleep, and mood reactivity. Paxil, short half-life, calming, sedating, may inhibit nitric oxide. Synthesis contributes to sexual dysfunction, sudden withdrawal, akinesia, GI upset, and tingling. Weight also can be a problem with Paxil. So you want to be careful of that. Most women do not want to gain weight. And if you don't tell them that they're going to gain weight on this, they're going to hate you. So you got to be upfront about it. So Luvox is a very short half-life, useful in psychotic and delusional depression, obsessive compulsive disorder, anxiety. Selective, better tolerated SSRI has mild antihistamine properties. Lexapro has no antihistamine properties. Low dose works. Fewest cytochrome P450 mediated drug interactions, and it's less likely to interfere with sleep, and fewer sexual side effects. And dosing is simple, 10 to 20 milligrams daily. This is the new medication, SSRI. The dosing is 5 to 20 milligrams daily. The common side effect is nausea. There's sexual dysfunction with an increase in dose. There's no dose adjustment necessary for geriatric or patients with renal or hepatic impairment. If you want to discontinue, you have to taper. You don't just come off of it. I did talk a little bit already about serotonin syndrome. This is life-threatening, caused by co-administration of any drug that increases serotonin due to excessive serotonin receptor stimulation. And again, the signs and symptoms of a high blood pressure, tachycardia, feeling of really, really being hot, flushing, sweating, diarrhea, and mental status changes. SNRI is a second-line therapy used in patients who have not responded to SSRI. They act on all three of the monoamine neurotransmitters. Precise mechanism of action is not clear, and examples of these are Effexor and Cymbalta. So Effexor has long-acting formulation, reduces side effects of nausea, has multiple pharmacological actions, can have discontinuation syndrome after long-term use, taper to discontinue. Prostic active metabolite can be helpful in pre-menopausal women. Cymbalta, painful neuropathy, cognitive symptoms, split dosing in those sensitive to side effects. These are the Serotonin Norepinephrine Reuptake Inhibitors. Third-line treatment, block reuptakes of norepinephrine and serotonin, block reuptake of dopamine to a lesser extent. Increase symptomatic neurotransmitter. And you want to, on this one, you want to prevent withdrawal reactions by tapering 25% per week, and that's key. You can't just come off of these meds. You have to taper and taper and taper. Tricyclic antidepressants are used for other things as well, for neuropathy. They're used for bipolar, and these are some examples of tricyclic antidepressants. And these are them. Again, we're not going near step-up dose. I don't prescribe, I've never prescribed a tricyclic antidepressant. I might have filled it for a patient, but I don't normally prescribe tricyclics unless I consulted with another provider who knows this patient, who is a specialist in this field. There's greater incidence of side effects than SSRIs with tricyclic antidepressants, and that's because they act on other receptor sites like the alpha-adrenergic receptors, the histamine receptors, and the muscarinic cholinergic receptors. And these adverse effects are cardiac abnormalities. They also have anticholinergic effects, which are dry mouth, urinary retention, constipation, and sedation, also weight gain, orthostatic hypotension, and sexual dysfunction. You want to caution prescribing this if there is a suicide risk. And also with tricyclics, they can be lethal in overdose. And so the suicide risk can cause them to die if they overdose on tricyclic antidepressants. That's one of the reasons why I don't prescribe it. It can cause major heart block because it can cause a prolonged QT interval. It can slow AV conduction, which could lead to heart block and arrhythmias. MAOIs are, they increase the amount of serotonin, norepinephrine, and dopamine in synapses. This is reserved for the treatment of refractory or treatment of resistant depression. Remember, the first line is SSRIs. Remember, you need to educate the patient about abrupt withdrawal, and they can get really sick. And some of the adverse effects are hypertensive crisis, and these are danger with foods or over-the-counter medications. So foods that are high in tyramine are like smoked, fermented, or marinated pork, chocolate, alcohol beverages, cheese, sour cream, and tofu. And tyramine occurs in plants and animals. The mechanism of action of the MAOIs are the monoamine oxidase is basically an enzyme that breaks down neurotransmitters, and those neurotransmitters are serotonin, norepinephrine, and dopamine in the synapses. This medication inhibits the enzyme and thereby increases the amount of neurotransmitters in the synapse. Adverse effects are, again, high blood pressure, orthostatic hypertension, sedation, insomnia, increased heart rate, dizziness, and sexual dysfunction. Norepinephrine and dopamine reuptake inhibitors, and those are example of that as well, Wellbutrin. They increase the levels of both norepinephrine and dopamine by inhibiting reabsorption into the cells. The precise mechanism of action is not clear. Thought that the increased levels help enhance neurotransmission, and that's basically the nerve impulse, the sending the nerve impulse, and thereby that nerve impulse improves mood. Considerations: contraindicated in individuals with seizure disorder or bulimia. Make sure you highlight that. Does not produce sexual dysfunction. Does not produce weight gain. Useful in treating seasonal affective disorder, dysthymia, and chronic fatigue syndrome. The Wellbutrin dosing is initially 75 milligrams twice a day, and then up to 150 milligrams BID, depending on the patient. Norepinephrine and dopamine reuptake inhibitors, the side effects are agitation, nausea, headache, loss of appetite, insomnia, increased blood pressure and heart rate, dry mouth, sweating, ringing in the ears, stomach pain, constipation, dizziness, more frequent urination. Other new antidepressants, trazodone's been around a while, but the drug is called serotonin antagonist and reuptake inhibitor. It's recommended for insomnia. Side effects are sedation, drowsiness, orthostatic hypotension, dry mouth, and ECG changes. Remeron is a serotonin antagonist, and its side effects are weight gain and sedation. So cardiovascular abnormalities and overdose have been infrequent and usually benign with trazodone. So that is that's very, very good. We like that. Bipolar disorder. So you're going to have a lot of patients with bipolar disorder. A lot of times, I just want to say this, that patients who misuse substances, can often present that they're mentally ill, and they're not. But there's a lot of patients that are mentally ill, like bipolar, and use substances. So just be very careful when you make that diagnosis, that, a lot of times getting them off of AE drugs or alcohol and seeing how they are is a lot of what providers will do. I think good providers, because, a lot of times you're agitated, you're this or that, you're hungover, you're withdrawing from medication doesn't necessarily mean you're bipolar. Okay, so bipolar is a recurrent mood disorder featuring one or more episodes of mania, hypomania, mixed mania, and depression, manic episodes that can last 3 to 6 months if untreated. Mania is associated with changes in antidepressants, steroid use, anticholinergic agents, and use of stimulants. So, anticholinergic side effects. These are some of the medications that have anticholinergic side effects. Muscle relaxants, antihistamines, antidepressants, antipsychotics, digoxin, nifedipine, oxybutane, Paxil, trazodone. So these are some of the things that can mimic mania. Steroid use and use of stimulants. Manic episode, persistently elevated or irritable mood, at least 3 of the following: inflated self-esteem or grandiosity, marked decrease in need of sleep, more talkative, flight of ideas, marked distractibility, increased psychomotor agitation, excessive pleasurable activities. 25% to 50% of patients with bipolar disorder have a lifetime risk of suicide attempt. Up to 15% of patients will complete the attempt, and those are ones with bipolar disorder. The treatment is cognitive behavioral therapy, psychiatric consultation, hospitalization, and mood stabilizer. Immediate psychiatric evaluation is required for all patients with suicidal, homicidal ideation. Approximately 25% of individuals with bipolar disorder will attempt suicide. Physician consultation is indicated for patients with psychosis or violent behavior. Lithium is used. You want to monitor kidney function if the patient's on lithium. And Depakote, you want to monitor liver function. Carbamazepine is an anticonvulsant and a mood stabilizer. So, bipolar treatment medications consist of antipsychotic, Zyprexa, Seroquel, Abilify, and Geodon. Benzodiazepines, high potency, Klonopin, mood stabilizer, Depakote, and Tegretol and Lamictal are also medications. I do not recommend benzodiazepines ever. So it's in the book, but this is something that you don't want to be responsible for having these patients dependent on these medications. And if they're drinking alcohol, which a lot of them drink alcohol because they're untreated, so they want peace, if you will, and that alcohol gives them the aha moment temporarily. But Klonopin and alcohol should never, ever, ever be used together. There's a high risk for death with taking both, and respiratory depression with Klonopin and both alcohol. Lithium therapeutic level between 0.6 and 1.2 must have frequent lab tests for drug level, and patient can become toxic if not monitored carefully. Must know kidney function prior to beginning this drug. You won't be beginning it, but you might be monitoring it. So the patients have to go back and forth, but you can draw it and then have the specialist sign it off and then write you a note for recommendations. Short half-life, it's excreted via the kidney, it's bound to sodium, highly toxic, and it's usually given in multiple divided dose. And patient must maintain normal sodium levels while they taking this. So you're going to be watching the sodium as well. Valproic acid, Depakote, therapeutic serum levels 50 to 120, unknown action, believed to increase GABA by either decreasing GABA metabolism or reducing its uptake. It's very effective for mania. Common side effects are nausea, somnolence, abdominal pain, and can be toxic to the liver and can increase ammonia levels. Maintenance treatment for bipolar is Lamictal. It also has prophylactic antidepressant and mood stabilizing properties. The dosage slow increase over 6 weeks to reach a target of 200 milligrams per day. You are going to adjust if on valproic acid. There is a risk of Stevens-Johnson syndrome, painful red or purplish rash, flu-like symptoms with this medication, with Lamictal. You want to start off very slow and not too rapidly increase the doses. I did want to mention a little bit about distinguishing between bipolar and unipolar depressive episodes. Unipolar is bipolar 1. And it's mostly basically the difference between bipolar 1 and bipolar 2 is that they don't have mania. They're not manic. But one of the questions that you do want to ask, there's a bunch of them, is ask all depressed patients about history of mania and or hypomania. Ask about family history of bipolar disorder. This is a loaded question. Family history is a clue to bipolar or unipolar. You want to actually involve family members or significant others in this screening process. You want to administer a screening instrument for bipolar disorder, such as mood disorder questionnaire, which I'm going to give you. There's an early age at onset less than 25 years is another cool clue for bipolar versus unipolar. Psychotic features are another clinical clue for bipolar in the seemingly unipolar patient, as is seasonal pattern. And also adverse or inadequate antidepressant response, meaning such as treatment for emergent hypomania or agitation, erratic or uneven antidepressant responses, multiple antidepressant failures, or treatment-resistant depression is usually bipolar. Anxiety, unpleasant, overwhelming, mental tension that has no apparent identifiable cause. It may be accompanied by physical distress and disruption. And these are all the anxiety disorders. Anxiety, just so you know, is normally a helpful emotion that acts as a warning to keep the body safe and out of danger. With an anxiety disorder, though, anxiety disrupts daily life. It's characterized by psychological and somatic symptoms in response to irrational fear. And the etiology is basically the CNS neurotransmitters. Also, the overstimulation in the autonomic nervous system, that sympathetic nervous system. So, generalized anxiety disorder, these are the signs and symptoms: palpitations, diaphoresis, tremor, nausea, diarrhea, sleep disturbances, impaired concentration, irritability, agitation, impending doom, motor restlessness, hyperventilation, tachycardia. Risk factors: family history, exposure to traumatic events, and genetic predisposition if a family member had it, generalized anxiety disorder. But the differential diagnoses are, do they have a hyperthyroidism? Do they have substance abuse withdrawal? I mean, I can't tell you how many people I see that say they have anxiety disorder, but they're on Klonopin, they drink daily, and they do cocaine. Who wouldn't have anxiety? Hyperglycemia or hypoglycemia, adverse medication effects. You want to take a look at all the medications. Are they having an arrhythmia that's causing this anxiety? Because if you have tachycardia or any type of underlying rhythm that increases heart rate, that's going to cause you anxiety. Stimulants. Are they drinking too much coffee? It's causing them to be anxious. Sorry, I'm yawning, guys. It's so bad. I'm in this room and it's like 100 degrees. It's a recording room. Diagnostic studies. You want to do a complete metabolic panel, which would include BUN, creatinine, electrolytes, and glucose, and a CBC, and TSH, T3, T4. So generalized anxiety disorder, these are the medications that I use. You also can use benzodiazepines, which is in your book, but I don't recommend them. Like, I can give you an example that they're effective short-term only for stabilization, but if you put your patient on benzodiazepine and an SSRI, they're going to stop the SSRI and want just the benzodiazepines. So I only will give it, maybe I'll give 1 or 2 pills if they're not sleeping, and it depends on who it is. If any history of substance misuse, no way, no how. And they're not going to be happy with you because remember, benzodiazepines are one of those drugs that are used illicitly, and they get them on the street. And a lot of patients are having seizures now because they're abusing benzodiazepines. We used to be able to reverse benzodiazepines with a reversal, and they don't recommend it. Reversing it if someone might be a suspicious overdose of benzodiazepines because patients now who have seizures that are on these are on such high doses because they're using them illicitly or prescribed. If we reverse them, they're going to go immediately into a seizure. So we're not using reversal agents on people that are not benzo naive. Patients that are benzo naive, like someone who's going in for an eye surgery and clearly has no history of benzodiazepine, we can reverse it if there's a danger of respiratory depression and you want, and that is probably the only time we'll reverse it now. Cognitive behavioral therapy, behavioral modification, and stress management. Also, medications don't work all by themselves. They have to be other things too as well. Also, the benzodiazepine are effective, but only for short course only. Clinicians should be cautious with long-term use, and that means greater than 2 weeks, carries a risk of dependence and withdrawal syndrome. These are the medications: non-benzodiazepine, no muscle relaxant or anticonvulsant effects. Mineral interactions with other CNS depressants, including alcohol. Buspar is a really good one, a non-benzodiazepine drug. And it has no muscle relaxant or anticonvulsant effects, which is good because the benzodiazepines do. And minimal interactions with other CNS depressants, including alcohol. So the mechanism of action works on the serotonin reuptake inhibition and agonist effects on dopamine receptors. These are other tricyclics. These are the tricyclic medications. Also, hydralazine is used. Atarax, Visceral, beta blockers also are used for stage fright or anxiety. But remember that comes with a risk with bradycardia. Alcohol use disorders, these are naltrexone is Vivitrol that's being used, and it's showing some really great usage for both alcohol and opiate abuse. The only thing is that you have to have that out of your system for, I think, 5 or 7 days. So you have to be completely withdrawn in order to get this medication for opiates or alcohol. And the opiates, they can't be in withdrawal. They have to be completely out of your system. So the naltrexone, the Vivitrol, you can take pills for 1 month, see how they do. And then if they do okay for those 30 days, then they can go for an injection. But we don't want to give the injection without trying them on pills, because the injection is for 28 days. Naltrexone competes with opiates for opioid receptors in the brain. An opiate antagonist, if alcohol is consumed, decreases the amount due to anti-agonist effect on the medication, This is another one that is used for alcohol abuse. It's not as popular as Vivitrol. It's basically has a modulating effect on receptors and glutamate receptors as well. Really, the mechanism is unknown as well. Used widely throughout the world since 1980. It was approved by the FDA in 2004. And basically they think, maybe they're hypothesizing that there's possibly a steadying a nerve circuit in the brain of alcohol-dependent person, and that's how it helps them. It also can work for anxiety, physiological dependence, negative family history of alcohol use disorder, late age of onset greater than 25. You might want to consider this if the patient does not respond to naltrexone, or naltrexone is contraindicated. This is another medication that's used for alcohol, particularly substance misuse. The dosage is usually 250 milligrams daily, ranges 125 to 500. And common side effects are dermatitis, transient mild drowsiness, peripheral neuropathy, psychotic reaction. And you can't use alcohol while you're taking this. You get sick as well as flagell, and you can't have any coronary artery disease. That's a contraindication of this medication as well. Topamax is not FDA approved. It's an anticonvulsant drug. It's used for the treatment for migraines as well as epilepsy. It's used for off-label for bipolar disorder, schizophrenia. It works on the sensitivity of the sodium channel modulator. It decreases alcohol-induced glutamate receptor sensitization. That is the mechanism of action. It stimulates GABA. It reduces the activity of glutamate and may slow release of dopamine in the brain's reward system, which I really feel like that's why it most likely will work. It increases days abstinence and alleviates alcohol cravings. Side effects are dizziness, tingling in the hands and feet, weight loss, temporary loss of memory, difficulty concentrating, cognitive impairment, and you want to titrate slowly to prevent side effects. So here's the cost. Topamax is $27. Naltrexone is $43. PO is $43. IM is $1,200. So, but this is not FDA approved, and it's category C, so you wouldn't want to use it in pregnancy. Obsessive compulsive disorder, constant repetitive actions, recurring thoughts, can interfere with ability to function, and basically you need to refer. This is not within your purview of management. Same as with bipolar as well. OCD is a chronic disorder. It most often occurs in families from one generation to the next. There's lots of screens. There's a youth screen for OCD youth. A lot of times you'll get adolescents that come in, parents concerned about their behavior. Panic disorder, recurrent, intense fear, abrupt onset, signs and symptoms, sudden onset, extreme anxiety, impending doom, shortness of breath, palpitations, numbness, sleep panic attacks. Treatment, long-term SSRIs, benzodiazepines is an option, but you guys aren't going to do that. Beta blockers and non-pharmacological interventions. And when I talk about benzodiazepines, you will all be monitored for prescriptions like benzodiazepines by the DEA and opiates. Non-pharmacological interventions, yoga, Tai Chi, Reiki. PTSD, exposed to extreme stressor, delayed reliving of event, signs and symptoms of nightmares, flashbacks, inability to recall specific events, emotionally labile, nightmares. That you can also use mini press is used for nightmares. I see that a lot. With cognitive behavioral therapy, it addresses the dysfunctional emotions or maladaptive behaviors and cognitive processes, like all my friends hate me, and that's with a therapist. Exposure therapy, too, for PTSD is a specific type of cognitive behavioral psychotherapy technique that is often used in the treatment of post-traumatic stress. These are some of the medications that are used for PTSD. And Buspar is considered an anxiolytic, meaning it lyses the anxiety. That's what that means. And Buspar, it suppresses the serotonin activity, but at the same time, it enhances the dopaminergic and non-adrenergic cell firing, which is, it works well with PTSD. I do want to talk a little bit about schizoaffective or schizophrenia spectrum disorders, which there's a you're not going to be managing people with schizophrenia as far as their medications go, but you'll be taking care of them. And there's also what will happen with patients that present with schizophrenia. The age of onset occurs earlier. Men commonly in the early 20s, and women may present in their late 20s to early 30s. However, in both males and females, there's subtle symptoms that may occur long before a definitive diagnosis is made, and males tend to have a worse prognosis and more difficult course. It's important to know this. The prevalence of schizophrenia in adolescence is low, but it can occur in childhood before the age of 13. Early onset points to a poor prognosis, although research is evolving. Family history of schizophrenia is a risk factor. Obstetric complication is also linked to schizophrenia, and developmental difficulties. History of abuse, major life events, and parental loss may contribute to the development of the disease. A certain cause of schizophrenia is not known. It is most known to be a multifactorial disorder consisting of biologic, psychological, and social factors. So if you were born in the city and you've been raised in the city, also if you have had social adversity and trauma, you have heavy use of marijuana use, and stressful life events all suggest increasing risk of schizophrenia. Also, if you're a migrant population, experience increased rates of schizophrenia, increased rates of social adversity and family disruption experienced by some migrant population. So I think, when we talk about schizophrenia, you might be diagnosing this in the office and referring them. So some of the positive symptoms refer to active qualities of symptoms, and they include like delusions, hallucinations, disorganized thinking, grossly disorganized or abnormal behavior. And delusions are the hallmark of positive symptoms, occurring more than half the patients. Delusions are fixed beliefs, not amenable to change despite conflicting evidence. This can include persecution, religious or grandiose themes. Hallucinations are sensory impressions without basis of reality, prompting thought disorganization. And they are vivid and clear to the individual experiencing them, and they may occur in auditory, visual, somatic, olfactory. And there's also schizoaffective disorder, which is different from schizophrenia. And its schizoaffective disorder appears to be 1/3 as common as schizophrenia, with an estimated prevalence of 0.3. The actual incidence is higher in females than males. Now, I did talk a little bit about the initial presentation most likely will occur in the primary care provider. The role of the provider for yourself is to identify and refer any suspected or new cases of schizophrenia for urgent psychiatric evaluations. And that might be difficult because there's not a lot of mental health providers. But the primary care provider is responsible to evaluate the patient's current risks to self and others. And any person presenting with psychosis for the initial or first break should be fully evaluated for underlying medical conditions. Consideration of substance abuse should be one of the primary differentials, and toxicology testing should be performed. And you should be screening for alcohol, opiates, cocaine, amphetamines, barbiturates. Hallucinogens are some of the most common offenders that can cause psychosis. So you don't want to say that they're psychotic or schizophrenic if it's due to substance misuse. And also medical conditions. You want to look at hepatic encephalopathy, low sodium levels, hyponatremia, hypoglycemia, hypoxia, intracranial bleed, infection, meningitis, and encephalitis. When I talk about the brain on fire, this was an example of a young writer who actually had encephalitis, but she was in and out of a psychiatric unit. And I find it very, 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 very interesting. So remember, when you look at someone new like this, you want to look at them for the very first time. And I want to say for any mental health, schizophrenia, bipolar, depression, you need to care. You need to take your stigma away and learn what is best for the patient, the family, and the community, because a lot of schizophrenics are not treated and they're homeless within our very own community. And there's also people that live at home with schizophrenia that are fighting to not show they have schizophrenia. So you as a provider have an important role to identify and refer and get the best treatment possible so they are not stigmatized, and they're living a good quality life.